Okay, let's dive into this. Here's our cognitive roadmap. First, anatomy and normal physiology. Second, functional adrenal masses. Third, non-functional masses and carcinoma. Fourth, acute adrenal insufficiency. And finally, hereditary endocrine syndromes.
Section 1. Anatomy and normal physiology, the baseline.
So you probably remember the classic rule of thumb for the adrenal cortex, moving from the outside in, right? GFR, salt, sugar, sex. The zona glomerulosa produces aldosterone, and that's triggered by angiotensin II and high potassium. Then you've got the zona fasciculata. That handles cortisol, driven directly by ACTH from the pituitary. And the zona reticularis produces your androgens, like DHEA. Finally, sitting right there in the center, the adrenal medulla is pumping out catecholamines to drive your sympathetic response.
Now, let's think about how that anatomy actually forms. The adrenal medulla is populated by neural crest cells, coming from the neural ectoderm. As they migrate during embryology, sometimes, some of this tissue gets left behind along the paraspinal axis, and that gives us a classic exam buzzword, paraganglioma. It's really just an extra adrenal pheochromocytoma that developed from those migrating neural crest cells. Moving on to Section 2, functional adrenal masses. Solving the mini mysteries.
Think of these hyper-functioning tumors as mini clinical mysteries, okay? Your magnifying glass here is strict biochemical algorithms. When working up hypercortisolism, algorithmic pacing is literally everything. If X, then Y. So step 1, confirm Cushing's syndrome actually exists. If a 24-hour urine-free cortisol or an overnight low-dose dexamethasone suppression test comes back positive, then, and only then, we move to step 2. Step 2 is checking basal ACTH levels to localize the source. If the ACTH is high, meaning it's not an adrenal issue, we jump to step 3. That's where we differentiate a pituitary source, which is Cushing disease, from an ectopic source using a high-dose dexamethasone suppression test.
And this brilliantly illustrates exactly what we just talked about. Start at the top to confirm hypercortisolism, check the ACTH right in the middle, and apply the high-dose dexamethasone at the bottom. Now, if the cortisol level suppresses by more than 50% on that high-dose test, boom, it's Cushing disease, an ACTH-secreting pituitary adenoma. But if it doesn't suppress, well, you're hunting for an ectopic ACTH syndrome, something like a small cell bronchogenic carcinoma.
Let's pivot slightly to primary hyperaldosteronism, commonly known as Conn syndrome. The absolute crucial distinction here is between an aldosterone-producing adenoma, an APA, and idiopathic bilateral adrenal hyperplasia, or IHA. Why does this matter so much? Because their treatments are complete polar opposites. An APA requires surgical excision for an immediate cure, but IHA, that's managed medically with a potassium-sparing diuretic like spironolactone. Surgery won't cure it. Since the stakes are so high, we actually use bilateral adrenal venous sampling to definitively tell them apart by comparing aldosterone to cortisol ratios.
Next up on our rapid review, the pheochromocytoma. The absolute highest yield concept you need to know here is the rule of tens. Rattle these off with me. Ready? 10% are bilateral, 10% are malignant, 10% are extraadrenal, 10% are familial, and 10% occur in children. So the really important takeaway here is if your patient falls into that familial category, you absolutely must check them for hereditary syndromes.
Take a look at this incredibly bright, hyper-intense mass on the T2-weighted MRI. That right there is the classic light bulb sign. It's a massive buzzword for the boards when evaluating hypervascular adrenal masses. Seriously, if you see a light bulb shining back at you on a T2 MRI, your brain should immediately scream pheochromocytoma.
Section 3. Non-functional masses and carcinoma, the silent threats.
These are often found incidentally, incidentalomas, which creates this clinical tension. Do we just monitor or do we cut? Well, when do we definitively cut? The number 50 is your anchor. Any adrenal neoplasm weighing more than 50 grams should immediately be considered malignant. And size matters tremendously too. Tumors greater than 6 centimeters have a very high probability of being adrenocortical carcinoma and absolutely must come out. Even masses sitting in that 4 to 6 centimeter range demand strong consideration for surgical removal.
And trust me, you do not want to miss adrenocortical carcinoma. It's rare, yeah, but it is exceptionally aggressive. Just look at the severe viralization and Cushingoid features before surgery, and then the vast clinical improvement after resection. A complete surgical excision of a locally confined tumor is really the only definitive chance we have for a cure.
Section 4. Acute adrenal insufficiency, life or death emergency. Now, in this scenario, your rapid clinical suspicion massively outweighs waiting around for labs to confirm things. If you've got a physiologically stressed patient who is suddenly hypotensive, lethargic, or frankly showing signs of shock, you have to act immediately. You perform a rapid ACTH stimulation test, sure, but you absolutely do not delay treatment for the results. Push immediate IV saline and dextrose, and here is the secret sauce to this step. Give 4 milligrams of IV dexamethasone immediately. Why dexamethasone? Because unlike hydrocortisone, dexamethasone won't interfere with the cortisol measurements of that ACTH stim test you just sent off. Once your patient stabilizes, then you can safely taper them down to standard hydrocortisone replacement.
Section 5. Hereditary endocrine tumor syndromes, systemic genetics. Now, what's really interesting about this is how isolated endocrine tumors suddenly reveal themselves as part of these sweeping, systemic, autosomal dominant genetic patterns. Notice how both MEN2A and MEN2B are directly linked by gain-of-function mutations in the RET proto-oncogene, and they both feature medullary thyroid carcinoma and pheochromocytomas. But look over at MEN1. It's driven by a completely different gene, the menin gene mutation on chromosome 11, and it classically presents as the 3 Ps: parathyroid hyperplasia, pituitary adenomas, and pancreatic islet cell tumors.
Because medullary thyroid carcinoma occurs universally across all MEN2 variants, deciding when to do a prophylactic thyroidectomy is strictly governed by the specific RET codon mutation. For MEN2B and the absolute highest risk mutations, that thyroid comes out in the first year of life. For standard MEN2A mutations, it's removed before age 5. And for the less aggressive variants, the cumulative risk of lymph node metastasis begins climbing rapidly in the mid-teens, which guides a slightly later intervention. So the genetic testing literally dictates the surgical timeline perfectly.
Let's finish up by putting this to the test with a direct clinical scenario straight from the source text. You've got a 50-year-old male with persistent hypertension, hypokalemia, high aldosterone, but a normal dexamethasone suppression test. Imaging shows a 1 centimeter benign-appearing adrenal mass. So what is the very next definitive step in management? Well, based on our rapid review today, you already know it's bilateral adrenal vein sampling before you even think about surgery. This really highlights a crucial theme here. In endocrinology, a single misplaced biochemical assumption can lead to totally unnecessary surgery, or worse, fatal delays. So as you step onto the wards, ask yourself, are you just trusting the obvious symptom, or are you proving it with the right algorithm? Thanks for joining this Rapid Revision Explainer. Stay focused out there, and we'll catch you next time.